Module 8, Gastrointestinal. This recording will cover Chapter 56, Coordinating Care with Patients with Oral and Esophageal Disorders. Our first condition we're starting with is stomatitis. So stomatitis is an inflammatory condition affecting the oral mucosa, dentition, and periosteum. Okay, so lining of the mouth. This is pretty common in patients who receive chemotherapy. If you remember, the medications used with chemotherapy, they target rapidly proliferating cells, and the cells in our mouth, along with the rest of our GI tract, are rapidly proliferating. So very, very common in patients who are having chemotherapy. Some other reasons could be related to a viral, bacterial, fungal infection, including herpes simplex virus. They're very painful. They can develop into an infection. So you can already see that that's going to be one of our health promotions. If they have stomatitis, we don't want it to get worse. So some risk factors, again, infections, irritants like alcohol, tobacco, mouthwash, radiation, and chemotherapy. Could even be caused from allergies, vitamin deficiency, or some other systemic disease. And then pictured here, you can see oral mucositis and oral candidiasis. So nursing management for this. So we want to make sure we're doing really good assessments of the oral cavity before, during, and after chemotherapy and radiation therapy, because it's something we know may happen and it's likely to happen, and we don't want to catch it when it's really, really severe. You want to make sure you identify, the trigger. What is causing this? What is making it worse? We want to definitely do aspiration precautions because we're dealing with the head, the mouth. We want to give the medications, whatever is ordered, and very commonly viscous lidocaine, which is pictured here, is ordered. So when you have a patient that has these really painful ulcers and inflammation in the mouth, the last thing they're gonna want to do is eat or drink. So not only do they have pain, but this is going to affect their intake, their nutrition. Many times patients just won't eat, and then they end up losing weight and they become malnutrition. So this viscous lidocaine, you pour it into a cup and they can they can swish it in their mouth and then spit it out. It numbs the mouth temporarily, hopefully giving them enough time to eat and drink something without having so much discomfort. And this can be done every 4 hours or even more frequently at bedtime. So this is something that you'll see commonly at the bedside. Also, water-soluble lubricants for the lips and mouth to prevent drying of that mucosa. So teaching your patient and their caregivers good oral care, good mouth care after each meal. We don't want any kind of food to be staying in the mouth, risk of bacterial infection. They should not be using alcohol-containing mouthwash. That will burn, that can cause more trauma to those ulcers. They should remove the dentures every night. Some people who wear dentures, they leave them on, but they should remove those dentures from the mouth because, again, that encourages bacteria to stay stagnant in the mouth. They should get regular dental checkups. They can rinse their mouth with salt water every 4 hours. Again, we're thinking to rid the mouth of, pathogens. And then dietary choices. So if you have a painful mouth with ulcers, maybe the ulcers are bleeding and they're really bad, then maybe they should not be eating crunchy, hard food. It should be soft food, non-spicy food, things like that. And then lemon glycerin swabs should not be used with stomatitis. Okay, these lemon glycerin swabs should not be used with stomatitis. A soft bristle brush can be used. So they should brush their teeth and use soft bristles. Again, soft bristle brush for stomatitis, and they should not use lemon glycerin swab sticks in the mouth. Next is oral cancer. So like I always say, you already know what cancer is. So this is oral, and this is what we mean with the oral cavity. So everything you see in this picture on the left is considered the oral cavity, including the soft palate, the tonsils, the posterior third of the tongue in the back, and the side and back walls of the throat. So if you have cancer in any of these areas, we say you have oral cancer. So what I want you to remember also is that whenever you have any condition in the head and neck, the throat, the mouth, the head, the nose, the eyes, these patients are already at your priority top list because that's where we breathe, remember, ABCs, and that's where our most vital organ is, our brain. So a patient having any of these issues going on is all of a sudden top of your priority patient list, okay? Okay, so the etiology of this type of cancer, we don't know. However, we do know that patients who use tobacco, drink a lot of alcohol, have HPV or other STI are more prone to oral cancer. Pipe stem has known to lead to oral cancer. Pipe stem is this little piece right here that sits on the lip when you smoke it. So as it sits there, it's an irritant and it can lead to oral cancer. Sun exposure, so that's like a type of skin cancer. So we can get cancer anywhere, and our oral cavity is no exception. So clinical manifestations: bleeding, raised area in the lip or mouth, ulcer in the mouth, discoloration, could be white, could be red in the mouth, like patches. There can be pain that actually radiates to the ear and neck. Patient can have difficulty speaking, difficulty swallowing. They can have odor in their mouth and eventual weight loss because they can't eat very well because of those issues, and even poor fitting dentures. So there are changes in the mouth. We're going to do a good history and physical. Of course, biopsy is the only definitive way to diagnose any type of cancer. There's a couple of different tests that can be run: scraping inside of the oral cavity and looking under the microscope. There's a Tuladine blue test. They put a dye on those cells and they light up. And then CT, MRI, PET scan for staging to see if the cancer has spread anywhere else. So treatment-wise, remember, cancer, the first thing they're going to consider is surgery because we want to get it out of the body. That's, cut it out. But remember where it is. It's in your oral cavity, so very delicate area, and it's going to affect a lot of different functions for the patient. So surgery-wise, we can do robotic surgery. It can be radical, partial, hemiglossectomy, a full glossectomy. Remember, that is, I'm talking about the tongue. Resections of the cheek, the floor of the mouth. So really whatever is needed, they're going to take it out. Any different type of combination. You can see in this picture, they did a partial hemiglossectomy. They took out a piece of the tongue. Non-surgical could be radiation, chemo. This might be because they have a tumor and they just can't get to it. So maybe they'll try medication and radiation to shrink it. The patient may need to have a surgically placed G-tube temporarily or maybe permanently for tube feedings for nutrition. So the goals for oral cancer is airway and also communication. You may not have thought about that right away, but if you're not able to use your mouth to communicate, that can be a huge barrier for the patient. Adequate nutrition for wound healing. Patient needs to eat still, even despite treatment and surgery and recovering. We need to make sure the patient is getting their nutrition. And then, of course, relief of pain and discomfort. So here in this picture, you can see some of those cancerous patches here in the mouth. And then you have lip cancer here. And then you can see this cancer on the third picture is pretty extensive in, looks like in the gum, between the gums and the cheek. So health promotion, good oral hygiene, look in your mouth and report any suspicious anything in there very early so that can be evaluated. Smoking cessation, I always say smoking is bad and it leads to lots of nasty things, including oral cancer. Next is oral trauma. So this refers to injury to specific bones of the face, including the nasal bones, mandibular bones, maxillary fractures, and any soft tissue injuries in and around the mouth. So it can be minimal to really, really major. It can be simple, it can be complicated. It can be a result of a blunt trauma or penetrating injury where something actually pierces the skin. Very common in car accidents, sports, fights. It affects everyone of all ages, young and old. A lot of times the younger adult may fall and have an oral trauma that way. So signs and symptoms, increased respiratory rate. Remember, again, we're talking about head and neck, so we're always thinking about breathing, our ABCs. So increased respiratory rate, stridor, which can be a clue to obstruction, so we want to take that very seriously. Shortness of breath, they can have oxygen desaturations, hypercarbia, which means they're retaining carbon dioxide. Tachycardia, changes in level of consciousness, oral bleeding, swelling and edema, loss of teeth, pain. So you can see this list of clinical manifestations. The first several are related to breathing, oxygen. And then, of course, we have the usual, which is pain and comfort, edema, and bleeding. So diagnostic-wise, we're going to get some labs to check for blood loss, infection, arterial blood gas to make sure that they are not retaining carbon dioxide and that their oxygen levels are adequate, and then imaging, facial x-ray, CT, or MRI. So for surgical management, there's several different types of surgeries, really just depends on what the problem is. In this picture here, you can see the jaw has been wired shut. This you will actually see pretty common. So what you need to remember is at the bedside, you have to have wire cutters, and this will be supplied to you by central supply. When a patient comes out of surgery, they will have wire cutters, kind of like this one in the picture, in a bag that you will tape usually to the wall at the bedside. And this is because what if something happens and the patient needs to be intubated? We can't intubate it if the mouth is wired shut. So you would just grab the wire cutters and literally just cut that open. Okay, really important. Okay, so back to complications, ABCs, aspiration, infection, and nutrition issues. So again, we want to maintain wire cutters at the bedside, and if the patient goes home, they should also have wire cutters available. We want oral humidification, give medications as ordered, that might be antibiotics, and a diet as ordered. So I remember having patients who are young, they got in a fight or they got in a bad accident and now they're in rehab with their mouth wired shut. So we would give them a lot of protein shakes, milkshakes, soft food, broth, blended up soup, stuff like that. And we of course want to monitor for signs and symptoms of infection. So next is gastroesophageal reflux disease, which is known as GERD. So this is a chronic syndrome of mucosal damage due to reflux of stomach acid into the lower esophagus. So let's look at this picture here. All right, so the picture on the left is a normal stomach. That's what it should look like. So we have our esophagus and there's our diaphragm. So our diaphragm is a muscle and it sits right here. So our stomach connects to the esophagus and it's right in between our diaphragm. So this lower esophageal sphincter, or LES, or remember it was also called the gastroesophageal sphincter, that is supposed to keep our acid in our stomach and not in our esophagus because the mucosa in our esophagus is not made to handle all of that acid. So in GERD, that acid, for some reason, creeps up through that sphincter that should have been closed, and it kind of sits down here in the esophagus, and it starts to irritate and inflame that esophageal mucosa. So the primary factor of GERD is an incompetent LES, meaning that that little sphincter that sits right here is just incompetent. It's not doing its job. It's not staying shut. It's not opening and closing as it should. So risk factors for GERD include a hiatal hernia, which we will talk about later, LES hypotension, loss of esophageal motility, eating large meals, delayed emptying of gastric contents, obesity, pregnancy, ascites, wearing tight belts or girdles, and the presence of an NG tube. So that makes sense because if you have an NG tube coming down the esophagus into the stomach, it's going to keep that little sphincter open. So keep that in mind also as a potential complication for any patient that has an NG tube. So diagnostics, well, if a patient is experiencing clinical manifestations like heartburn, atypical chest pain, which means that they're not following the pattern of, a myocardial infarction. They're just kind of having this may be chest pain that happens after they eat or something like that. Painful swallowing, bleeding, they can develop cavities in their teeth. The acid actually makes its way up all the way up the esophagus into the mouth, and they can feel it in the back of their throat. Morning hoarseness, laryngitis, pharyngitis, bronchitis, regurgitation, and respiratory symptoms. Our stomach sits very closely to our lungs. So if you start to have all of this inflammation in that area, it can actually start to have an effect on our lungs, which is where those respiratory symptoms start to happen. So when a patient starts experiencing this, they typically will come in with the same set of signs and symptoms, same subjective complaints. So a good interview is really important. If they're not able to figure out that it is GERD based on a history and physical, then there are other studies that can be done, like an upper GI endoscopy, which we know with biopsy. They can do an esophagram. If you remember, that's where they drink the barium and it lights up and they can kind of see what the esophagus looks like. A motility study, also known as a manometry study. That's where they insert a tube with like this little balloon at the end that can measure the pressure of that sphincter. pH monitoring to see if there's a lot of acid coming up. And then there are some nuclear medicine studies that can also be done. Again, we want to start with least invasive and less expensive first. So we're going to see how we treat it on the next slide. So these are some other reasons why GERD may happen. So we talked about LES dysfunction. That's an incompetent lower esophageal sphincter. But it can also be lots of other reasons. For example, impaired esophageal motility. So remember, our esophagus has these wave-like constrictions that help to push our food down. If there's a problem with those wave constrictions, then you may develop GERD. If you have a defective mucosal defense, so maybe you're on a medication that is lowering your immune system, or maybe some other genetic issue that is affecting the mucosa here, then that can cause issues. Delayed gastric emptying, small intestinal reflux of bile. There are many things, but the most common problem is going to be a dysfunction of this sphincter here. All right, so what are we going to do about this? So the first line of defense is going to be lifestyle changes. So if a patient comes in and they fit the criteria perfectly, then the doctor will likely say, hey, change your lifestyle. And also, they're going to give PPIs, proton pump inhibitors, or histamine receptor agonists, H2 receptor blockers. So those medications are very, very effective in reducing the amount of acid that's produced in the stomach. And alongside with lifestyle changes, that's usually going to be the first thing that the provider does. They'll do it on a trial basis, and if it goes away, great. And if not, then they may do the more invasive testing and diagnostic procedures. So when you educate your patient, they should be eating a low-fat diet. They should eat the smaller meals, and they should have fluids in between meals, not with their meals. They should avoid irritants like alcohol, caffeine, and smoking, and foods that will decrease that LES pressure. So chocolate, peppermint, they should stay away from those. They should avoid drinking milk before bedtime, and they should stay upright for at least 2 to 3 hours after they eat. So hopefully gravity will help the food go down. If you eat and then lay down, it kind of helps the food to kind of regurgitate back up. So we want them to sit up, let gravity help the food go down. Avoid tight clothing and bending over after eating, because that will increase the pressure. And they should just not eat 3 hours before bedtime, because when you go to bed, you lay down. We want the food to be like out of the stomach. Elevate the head of the bed when you're sleeping. Very, very important. Weight reduction, because all of that extra adipose tissue applies pressure to that LES. That's a major risk factor for GERD. And drug therapy. They need to take those PPIs and H2 receptor blockers. So the PPIs actually work better than the H2 receptor blockers, but if the PPI isn't enough on its own, they might put in a combination. And antacids. And remember, these medications should be taken as directed, because if you take too many antacids, we know you're going to deplete your stomach of acid, and you can go into a metabolic alkalosis. Surgical therapy is usually not necessary. Again, medication and lifestyle changes are usually effective enough. However, GERD can lead to ulcers and something called Barrett's esophagus, which is pictured here. So these are like thickened patches. It shows up red in the mucosa, and it's from recurrent inflammation. That tissue becomes thick, and it can lead to cancer. Also, strictures. When the esophagus is inflamed repeatedly, recurrent inflammation, it kind of builds up, and it can become very, very tight and narrowed, and eventually it can lead to an obstruction. So those are complications that may require surgery. And there are several different types of surgery. This is the one your textbook emphasizes, so I'm going to go over this one. This is a laparoscopic Nissen fundoplication. So fundo refers to the fundus of the stomach. If you remember, that's the top part of the stomach. So if you see in this first picture here, they take the little fundus, which is usually like this, right? They pull it, they wrap it around the esophagus, and then they tighten it right here. And it provides support, and that is one surgery that's done for GERD, but not just any GERD again, severe GERD that's leading to other complications. So what you want to remember with this is you want to monitor for bleeding. And I'm going to bring up the NG tube again. When you have an NG tube placed during surgery, you want to make sure that you are not doing something you're not supposed to do with that NG tube. So you always need to look at your doctor's orders. Does the order say that the RN can flush that tube? Can they aspirate from that tube? Can they instill medications in that tube? Or whatever it is. So you want to make sure those orders are very clear. This patient that has this procedure is likely to have an NG tube placed during surgery to suction. So as part of your assessment of your GI system, your focused abdominal assessment, you're going to check the contents of that suction canister. The color of what is coming out is very important. So after surgery, there might be some fluid in there. There might be a little blood. It might be brown. It might be serous, serosanguinous, maybe a little sanguinous. But you need to recognize what is expected after surgery and what could mean a complication is starting to happen. So if you come in and the patient had surgery and you see bright red blood, you should think, well, bright red blood is somewhere in the upper GI tract. Okay, so if you're vomiting bright red blood, if you have an NG tube placed to suction and the canister has bright red blood, there is something actively bleeding in the upper GI tract, the stomach, the esophagus, somewhere up there. And if it's after surgery, then that needs to be reported. Okay, that needs to be reported. Before you report it, you do have time to assess your patient and get vital signs. Okay, so make sure you just don't call the doctor and say there's bright red blood in the canister. That's not enough information. It is reportable. It is urgent, and it could mean the patient needs to go back to surgery, but you have to do your assessment. Okay, I'm going to say it again. If a patient is having this type of surgery, and there's other examples of other types of surgery, but since we're talking about this is the example I'm giving you. If they've had a laparoscopic Nissen fundoplication, and they've come to you post-surgery and they have an NG tube in place and you're checking the canister and you're like, wow, there's a lot of bright red blood in there. That is not normal. Let me check the patient's vital signs, because I know the blood pressure can tell me there is a really good indicator of fluid volume, okay? And also, if you lose a lot of blood, you're losing the ability to carry oxygen to your body. So I might want to do a neuro check. Hey, are you confused? Are you having any kind of, right? You then get that information and then you call the doctor. But this is a priority patient because it's circulation, right? The bleeding, but it's also breathing, because think about where it's located. Okay, very important. Now we have our hiatal hernia. So up here, so the image on the left here is our normal stomach, and this section here is called the hiatus. So when you have a hiatal hernia, that's the piece that we're talking about that's becoming abnormal. So normally the esophagus comes through here, connects to our stomach, and we have our diaphragm here. Again, our diaphragm is a very, very strong muscle, and it divides our abdominal cavity from our thoracic cavity. When we have a hiatal hernia, there's a weakened muscle in the diaphragm, and this hiatal part of the stomach kind of seeps on through and it creates this bulge. And this can happen for a few reasons, but usually it's because that diaphragm, the muscle, is weakened in an area, or there's a lot of increased abdominal pressure that kind of pushes that stomach through this opening. So some risk factors: residing in Western countries. So that is an interesting risk factor for a hiatal hernia. So the reason that is because in Western countries, we lack a lot of dietary fiber. Okay, so that means when we have bowel movements, if you don't have enough fiber in your diet, you tend to strain. Okay, you tend to strain, you push, and you increase your intra-abdominal pressure. In addition to that, in Western countries, we are considered to have an unnatural sitting position when we defecate. So when you go to other countries that have a more natural, it's kind of the squat, it's kind of like a position of squatting is actually a more natural position. They really have a low prevalence of hiatal hernias. So all this is very interesting. Moving on, obesity, that contributes to that increased intra-abdominal pressure. Pregnancy, same thing. And smoking, again, smoking is bad, causes a lot of problems. Two types of hiatal hernias, type 1, type 2. Type 1 is the sliding kind. It's the most common. So this is the one where when you lay down, it kind of, the position and gravity, that hiatal part of the stomach kind of slides on through that weak diaphragm muscle wall. But with sliding, once the patient is vertical, it kind of slides back down into place. So it doesn't tend to be too troubling, and sometimes the patient doesn't even know they have it. Type 2 is paraesophageal, also called rolling hiatus hernia. This one is less common, but it's more potential. It has more potential for complications, because if you look at this picture, unlike the sliding hernia, it doesn't go back down. So this little piece gets up in here and it stays there. So it can cause strangulation, the blood flow can stop. It can keep pockets of food in there and it becomes rotten. So we don't want any hernia, but we definitely don't want the paraesophageal hernia. Also, I just want to tell you that some people have these for their entire life, a hiatal hernia, and they never know. I had a patient who came in her 70s for something completely unrelated to a hernia. They did a chest x-ray and she had a big old hiatal hernia and she didn't know. No signs and symptoms. They didn't do anything for it because it was asymptomatic. So these things happen. Weird things happen in our body. We have no idea. But if we all had MRIs done, we would find out a book full of things wrong with us. So what are we going to do about our hiatal hernia? Again, I said a lot of times they're asymptomatic. If they start to have signs and symptoms, it's going to be very similar to GERD signs and symptoms: heartburn, regurgitation, so you can feel kind of acid and food at the back of your throat sometimes. It can cause some chest pain, some difficulty swallowing, burping, or belching. The type 2 kind, which is the most severe, they can feel full after eating, maybe breathlessness after eating, feeling of suffocation, and the symptoms get worse when they're lying flat. Okay, very actually similar to GERD overall. Complications include GERD. It can cause gastric reflux, esophagitis, where your esophagus is inflamed. It can cause ulcers, hemorrhage, stenosis, which is a very, very strickening of the esophagus, strangulation, and aspiration. So management. If we can do this without surgery and medications, let's do that. So we already know that increased intra-abdominal pressure can cause this. So if the patient's obese, then we would like them to reduce their weight. For example, medications, very similar to GERD, antacids, PPIs, H2 receptor blockers, and some complementary medicine can also help with hiatal hernia. Surgery, that's when all of our efforts have failed and the patient still doesn't have a relief, or it's one of those type 2 hiatal hernias where it's being strangulated and you have to do surgery no matter what. So it really just depends on how severe it is which type of surgery they're going to do. Diagnostics to find this out: upper abdominal x-ray, endoscopy, barium swallow, or an EGD. So teaching, we want to limit foods that are spicy, that have caffeine, chocolate that are carbonated, acidic drinks, peppermint, alcohol. Again, this education is very similar to GERD, so they shouldn't eat right before bedtime or before lying supine on their back. They shouldn't wear restrictive clothing that will put increase abdominal pressure, maintain a normal weight, stay upright after eating, and then if they do have surgery, then we want to educate them on post-op, their post-op education. Just a few gerontologic considerations for GERD and hiatal hernia. So this actually becomes more prominent as we get older, and some medications that patients may be on can actually decrease that LES pressure, which can cause, an issue with GERD or hernia. So nitrates, calcium channel blockers, and some antidepressants, so just keep that in mind. And then you can also have medication-induced esophagitis that can be from NSAIDs. We know that NSAIDs have a potential to cause GI bleeding. And potassium. The first sign of GERD or hiatal hernia in the older adult may actually be severe versus a younger person who it's kind of subtle and it comes on over time. With the older adult, they may just start having esophageal bleeding, or they just might start aspirating. So either way, for the older adult or the younger person, the management is still the same. So now we're next with esophageal cancer. Again, we know all about cancer. This is esophageal cancer, so we want to start thinking breathing, airway, nutrition, all of our ABCs. Very, very sensitive area, right? So esophageal cancer is typically fast growing, and it quickly spreads to the surrounding lymph nodes. And more than 50% of people who are diagnosed with this experience metastasis. So the signs and symptoms: progressive dysphagia. So these patients will say, I started, I wasn't able to really drink thin liquids very easily, or then maybe I had to kind of eat chopped foods, and then they went to soft foods and then puddings, and then now they can barely swallow, thin soft foods. So it's a progressive dysphagia. Swallowing becomes more and more difficult, and that's because there might be a tumor in there. There might be inflammation in there, constricting. They might complain of hemoptysis, so blood in their sputum. That's from tissue breakdown. Burning sensation in the middle of chest, painful swallowing, vomiting, and then of course weight loss is a definite sign because of two things: whether the cancer metastasized or because they're just not eating, they're not able to eat as much, so they're losing weight. Hoarseness and melena. So what is melena? So melena is stool with blood. Okay. So melena is like black stool, okay, but black blood. So we also say black tarry stool. Another word for black tarry stool would be melena. Okay, so diagnostics. We're going to do our EGD, where we go in and take a look. We can do an endoscopic ultrasound, barium swallow, CT, and PET scan. So management, again, we would prefer surgery because it's cancer, but it's really going to depend on the location and the stage of the cancer and the goal. So if a patient who is 75 years old with esophageal cancer, a big extensive surgery may not be the priority for that patient, and what they want. So there's all different types of approaches that they can go with this. They can take a piece of the esophagus and then connect the two pieces that are left together. They can remove the whole esophagus. They may have to take out part of the stomach. So it really just depends. Most of these patients are going to have a combination of radiation and chemotherapy. It may be done before surgery to kind of shrink the tumor. Just really depends. And we also have to keep in mind nutritional therapy. So these patients may have to be on TPN or G-tube. They may they're definitely going to need some type of IV fluid, so just keep that in mind, the nutrition part of it. And again, I'm going to say it again, if this patient came out of surgery with an NG tube, nasogastric tube, you got to be really, really careful and make sure you have doctor's orders to do anything with that NG tube. Complications, dysphagia, of course, strictures dumping syndrome, which we'll talk about at a later date, stomatitis, nausea, vomiting, and diarrhea. So just GI general, GI upset. For the nursing interventions, make sure you maintain the head of the bed at least 30 degrees. We don't want them to be flat. We don't want things to come out of the stomach up into the esophagus. Definitely get a dietitian or nutritionist on board. We want high calorie, small meals throughout the day, and get a speech therapist on board to evaluate swallowing. Teaching, we want to let the patient know post-op, what to expect after that. These patients that have esophageal surgery will likely be in ICU post-operatively. We want them to cough, deep, breathe. Again, ABCs, number 1, early ambulation, pain management, nutrition, dental screening, and of course all of that post-op education. This is a picture of esophageal cancer. Of course, the deeper it is, the worse it is. Once it's spread, we call that metastasis. The picture on the right is a real picture of esophageal cancer. Again, this slide, I pretty much went over it already. So acute care before the patient has surgery. This can be very scary. It's in a very delicate area, so you want to make sure you provide support. Again, high calorie, high protein nutrition. After surgery, they're going to be in ICU. We want to monitor for complications whenever we have surgery on anything that we cut and connect back together, like a tube, like the esophagus or intestines, where it meets together. We call that an anastomosis. That can leak, so we have to be on the lookout for that potential complication. Fistula formation, pulmonary edema, acute respiratory distress. So these patients are going to have an NG tube for about a week, 5 to 7 days, and the drainage that will be coming out at first will be bloody, could be greenish to yellow. Again, we do not irrigate, we do not reposition, and we do not reinsert that NG tube. Cannot stress to you how many times you need to make sure, if you need to do something like that, you check to see if there's an order first for you to do it. If not, you call a surgeon. They're going to come down and do it. These patients may also have a chest tube post-operatively. We want to prevent respiratory complications. You guys are good. You know this. Turn, reposition, cough and deep breathe, and septus barometer, aspiration precautions. VTE prophylaxis, that is venous thromboembolus prophylaxis, so blood clots. So that's the compression stockings. That is the sequential compression devices that squeeze the legs. That's repositioning. That's early ambulation. That is doing range of motion with the ankles. All of those things will help prevent blood clots. And then teaching your general post-op care, pain management, ambulatory care. So when they go home, you just want to make sure they follow up, because this is cancer. We want to make sure it doesn't come back. And maintain good oral hygiene and a healthy diet. Esophageal trauma. So you hurt your esophagus, and again, just like oral trauma, it can happen, blunt force, car accident, a fight, all of those things. So the most common causes may be ingestion. Okay, so you may have seen stories where patients are trying to hurt themselves and they'll drink bleach, or they'll drink Drano or some other kind of poison household liquid that they can find. So once they swallow that, that is poison, and it's just going to melt the inside of the esophagus. So that's esophageal trauma. Blood injury, open penetrating wounds. Maybe they have a foreign body. Maybe they were eating fish and they had a fish bone stuck in their esophagus. All kinds of stuff. Tube placement. It could be a tube like a breathing tube or a feeding tube. That can also cause trauma in the esophagus. Spontaneous rupture, and that is a thing also. Diagnostic chest x-ray, CT, or esophagography. Medications, antibiotics, corticosteroids for inflammation, pain meds, or even some topical pain meds. So complications that can happen from this, I think you can probably tell me what they are, even before looking at this list. Infection, abscesses, sepsis, shock, obstruction, aspiration pneumonia, bleeding. These patients will have a NG tube, low intermittent esophageal and gastric suction. They should be NPO, provide nutrition, antibiotics, pain management.